Here we go. Okay, I would like to welcome everyone to Compumedics USA's webinar series. My name is William Oliver. I'm the Curry Application Specialist here at Compumedics USA. Compumedics NeuroScan proudly presents the quarterly Curry webinar series, NeuroTalks, focusing on sharing research and clinical practices around epilepsy and other primary brain disorders, facilitating communications among scientists and clinicians, and inspiring new advancements within their fields. This webinar series will be held on a quarterly basis. We will announce the NeuroTalks date and time and registration information in our quarterly Curry newsletter, as well as the NeuroTalks flyers, which you should receive through emails or social media such as LinkedIn. Before we begin, allow me to read the disclaimer to fulfill the due compliance requirements. I'm just going to share my screen here. The information in the NeuroTalks webinar represents the views and opinions of the presenter and does not necessarily represent those of Compumedics. Compumedics does not make any representations or warranties regarding the accuracy, applicability, fitness, or completeness of the information presented during the talks. The information presented in the webinar is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Compumedics does not seek product promotion, sales generation, or any other commercial value through this webinar. Okay. So today it is my great pleasure to introduce you to our speaker, Dr. Benjamin Brinkman. Dr. Brinkman is a professor of neurology and associate professor, of engineering at the Mayo Clinic in Minnesota. It is his unique role bridging engineering and clinical practice. Dr. Brinkman works directly with patients while also informing cutting-edge research. His efforts are focused on developing innovative seizure detection and prediction capabilities using non-invasive and minimally invasive biosensors. Additionally, Dr. Brinkman is working to improve the accuracy of pre-surgical seizure evaluation through novel methods for analyzing medical images and neurophysiological data. Dr. Brinkman's pioneering work has led to the development and implementation of enterprise-wide analytics supporting pre-surgical epilepsy evaluation at Mayo Clinic. He has also made significant contributions by applying specialized methods to verify the placement of stereotactic electroencephalogram, or stereo EEG, electrodes for epilepsy patients. With his remarkable expertise spanning neurology, engineering, and data analytics, Dr. Brinkman is at the forefront of advancing epilepsy treatment and care. His talk today is entitled EEG Source Localization, Technical Considerations, and Correlation with Intracranial Monitoring. Following the talk, there will be a 10-minute Q&A session, and Dr. Brinkman may have some sprinkled in as well. You may submit your questions through the Questions tab during the talk in the top right corner of your screen. We will present them to Dr. Brinkman at the end. Please provide your name and the organization name along with your questions. And now, please join me in welcoming this distinguished researcher and clinician, Dr. Benjamin Brinkman.
Thank you, William, and thanks everyone for coming today. Really appreciate it, and thank you to Curry, the Curry team and the Compumedics USA team for having me. It's a real privilege to be here today and to talk to you about some of the things we've been working on. Let's see, I need to share my screen. It looks like it's disabled at the moment.
I got you.
There we go. Excellent. Thank you. All right. Is that projecting well?
Yes, looks good for me.
Excellent. Excellent. All right. Well, and thank you, William, also for that kind introduction. We've really enjoyed working with Compumedics and found the Curry platform to be immensely helpful in our work, and both in the clinic and in our research work. There we go. I'm going to start with the basics here today about EEG and about EEG source localization or EEG source imaging. Um, of course, as I think anyone with a neuroscience background knows, you're looking at the cortex. Uh, what we're trying to capture is depolarization in cortical columns here, which creates essentially a dipole. Now it's a distributed charge distribution with negative charge typically outward and positive charge inward. We measure those potentials on the scalp surface, of course, with these little blue circles are supposed to represent the scalp electrodes, and that's where our EEG comes from. That's the signal that we're looking at. That the time series, the squiggly lines that the neurology team's so good at interpreting. And of course, you can map all of those different potentials at all the measured scalp electrode positions. And this is an isopotential map. It's a bit like a topographic map if you've ever gone hiking in the mountains and, like an elevation map, but for voltages instead. These can be, I think, pretty helpful for understanding what's going on, identifying, where depolarizations are happening and where dipoles are. And that's what we do, of course, with EEG source localization. We explicitly model this charge separation as a single point dipole with a negative end and a positive end. And of course, we know this is a model. It's a partially inaccurate model. We know that it takes a certain amount of cortex depolarizing simultaneously to create a charge distribution that we're able to measure on the scalp. It's not a point source, but having a point source simplifies the math quite a bit, and it's a very useful very useful abstraction, I think, nonetheless. And of course, we don't have to use that simple point source. We can do current density solutions, which assume that the activity is distributed across the cortical surface, and that there's that what we measure on the scalp is summated or is summed from multiple sources in the cortical ribbon. And of course, the algorithms do this by taking the MRI, modeling the conductivity of the skull, the scalp, if there's muscle um, underlying the skin, that's taken into account as well. And these models they can be fairly simple, they can be fairly complex as well. And just a note here, this is one interesting thing about this problem is it's a very ill-posed problem, which is to say that we may have 32, 76, or 128 measurements on the scalp. In terms of intracranial locations where potentials could be arising from, it's nearly infinite. So the inverse solution algebraically is not solvable. However, the forward solution is. So if we have a certain dipole, we can uh, project out and measure or mathematically model what that scalp potential distribution would look like. And that's in the background, that's how all of our algorithms work. It's an iterative solution. There's a starting point, and they're always solving the forward problem, which is to say, given a charge distribution intracranially, what would you measure on the scalp? And then trying to satisfy certain constraints and iterate until we have an answer that's good enough. And this is so that was all an illustration. This is a real case and a real head model, and this is what something like this might look like with your current density solution in orange and red here, and your dipole in blue down there. One of the more important aspects of, in terms of accuracy in your final solution, is how you model the head. And there's several different possible assumptions you can make. Uh, Back in the old days, when computational speed was very limited, a simple spherical head model was good enough. You can see here it probably approximates the cortical surface well enough over the vertex and over the convexity, but down in the temporal lobes, of course, the basal area of the brain, it's really quite different from the shape of the brain, and of course that's what we see typically. I think dipoles from the temporal lobes were very misplaced using this model, and dipoles up around the convexity were better. Um, of course, you can get a little more complicated and do a four concentric shell model, and that allows you to model the compartments a bit better. Still, the geometry is not very realistic. Um, One thing that we're able to do now is an atlas-based model, which is a sort of a generic average brain, uh, and that's of course a fairly realistic head model and with fairly realistic conductivities. And this is, I think, a good option for patients when you don't have an MRI or you're not able to get a good segmentation of the patient's brain. Of course, the best way to go is a boundary element model of the patient's own brain, skull, and scalp, and CSF. That's going to give you the most accurate results. Um, in our practice, this is what we do all the time. Uh, and I guess if we don't have an MRI, which is really, really very rare for us, we would use the atlas-based approach to model the head. And just to further kind of make this point, looking at where the electrodes are on a three sphere head model um, versus compared to a patient specific boundary element model. Of course, one of the things that's been talked about a bit in the literature, and it's a good question, is how many electrodes do you need to do this accurately? Um, I think you know, the literature has dealt with this a bit, and my understanding is when you get up to about 120 electrodes on the scalp, uh, as you increase the number of electrodes up to about 120, you're gaining accuracy. You're sampling the brain better. Beyond 120, you really start to plateau off in terms of your gains. So we do some 32 channel low density studies. You can see the electrodes are pretty far apart, though. It's challenging. I think what we end up with is I'll say it's accurate, but it's very low resolution, so it's very broad. We do quite a bit of 76 channel high density analysis as well, and that I think is more reliable and more focal results are possible with that approach. And then off to the right here is a 128 channel high density. This is a geodesic cap, and this is great. Our problem is or the challenge, of course, is to keep something like this updated and recording well. That's a lot of time for the techs. Practically, oftentimes the patients, if you're gluing individual electrodes on, it takes a long time, and the patients have a hard time sitting still for it. So we're often operating here the 76 channel high density range, and not so much in the 128 channel. We do some routine EEGs with this with 128 cap as well, and those could be helpful. We do like to record seizures though, and of course that's hard to do in a routine brief EEG. Same point here. Just looking at the models from the side. Interesting thing about the geodesic cap, of course, is it has all these electrodes down on the face and neck. The goal there is to try to sample this basal temporal area, the inferior surface of the brain. Obviously, that's a challenge. We can't really um, you can't really sample it without, I guess, using an invasive electrode, which isn't really appropriate at this stage. So it's a decent approximation. We always use the subtemporal chain in our practice. P10, TP10, T10, and we often use TP12 as well. And I think that's a very important thing to include if you're going to do EEG source localization. A couple of practical considerations here. Of course, I talked about how dipoles are modeled as point sources. This means, from the geometry of things, that they're always placed deeper than the cortex generating them. You can think of it, a good way to remember this, and just a shorthand is, think of it as a flashlight analogy here. You look at the dipole. It's a bit like a flashlight shining on the cortex that generates it. So, and I've been to a couple of Dr. Ebersol's talks, and one of the things he recommends is looking down the axis of the dipole and thinking about where's the sheet of cortex that could have generated this discharge. And I think that's a great thing to do. I think that can be very helpful. Um, and then we really like the current density models in our practice. They've been very helpful, and they sort of provide an intuitive visualization of the activity. Just remember, there are a couple of caveats with this. First of all, you can choose a 3D grid versus a cortex solution, and off to the right here, you see the difference. We try to favor the cortically constrained solution when we can. We know that's a little closer to reality, but sometimes we do go back to this 3D grid if for some reason, maybe our segmentation's off. This is a good example here. You can see that the tip of the ventricle was missegmented as cortex due to partial volume effect. Or if we think maybe there's a focal cortical dysplasia with a transmantle sign, and maybe the activity could in fact be coming from what our algorithm would classify as white matter. That's another reason we might use that grid solution instead of a cortically constrained solution. Also, down here at the bottom, the threshold that you apply can really change the appearance of this, whether it's the grid or the cortically constrained solution. It's the same story. You can make it look very focal just by changing the threshold. So it's important to remember to, when you're evaluating these solutions, look at the center, look at the peak, the peak probability from the current density model, and kind of move outward from there and think about it that way. If you're looking at these edges, you're looking at something completely arbitrary. And this is an example of just an interesting study we did here. We had some people who were implanted with a 4-lead DBS system, 2 leads in hippocampus, 2 leads in anterior nucleus of the thalamus. This is the Medtronic RC+S system our group has done a fair bit of research on. And we had these people put on a geodesic sensor net, and we actually turned on stimulation at a very low level and mapped the stimulation pulses just as a validation with our system. And you can see here this in the left temporal lobe, our dipole and our S Loretta, that's the current density model we used. Very accurate, very close to where those hippocampal electrodes are. So that was anyway, just a very interesting little experiment that we did. There are quite a few studies out there supporting the use of EEG source localization. This is one of the classic ones from the Ebersol group, of course. This was focused on dipole modeling. This is an interesting point that's been, I think, a point of debate in the field a bit. How much cortex is needed to provide to generate a spike that you can measure on the scalp surface? I don't know the answer to that. Dr. Ebersol's paper suggested maybe 10 to 20 square centimeters. More recent data suggests that might be a bit of an overestimate. But when you think about it, it is a fair bit of cortex that's required. So again, just driving home the idea that these are not point sources, they're not point depolarizations. There's an area of cortex that's depolarizing, and just to keep that in mind. And one thing also to keep in mind, I think, with EEG and EEG source localization, the orientation of your dipole does matter quite a bit. So you have these different patterns here. So number one is the sort of dipole that's oriented, we'd say, tangentially. So it's perpendicular to the radius. And you're going to see something, when you look at the scalp, you're going to see a pattern, something like this, number one, where you see the negative end of the dipole on one side of the brain, positive on the other. Number two is maybe a little simpler. You've got the negative end pointed outward. You're going to see a fairly broad distribution there. Number three, I think, is a hard one. This is a situation that where EEG might miss, depending on if this sulcus is deep enough and if this depolarization is deep enough. Of course, you've got negative potentials on the inside, positive potentials, uh, um, all around, and it's going to look like a very low amplitude spike, I think. And then, of course, for the basal temporal depolarizations, they're hard. Again, the importance of the subtemporal chain of electrodes, hard to overstate that. And even with those, you still might miss those. I kind of feel like our basal temporal localizations are a little less accurate as well than the other ones that we do. I don't have data to back that up. That's just my sense. This is a paper from the Geneva group. They're a very accomplished group. Large study, 152 people with epilepsy, post-operative results compared to a number of different pre-surgical modalities, including high-density EEG source localization, looking at interictal spikes, and they used a LoRa current density solution. Um, which is a fine model and reasonable way to go. Interestingly, they found that the sensitivity and specificity of EEG source localization with high density was better than any other modality out there, better than MRI, better than PET and SPECT. And low density EEG source localization did well, but it was not as good as high density. And I think that's all very intuitive, other than, of course, I don't know that I would have expected EEG source localization to do better than MRI, PET, and SPECT. But I've seen other data since this paper came out, of course, that I think affirms this, and this is a very helpful part of pre-surgical evaluation in epilepsy. This is a paper from our group somewhat recently. Ben Cox did a wonderful job leading this effort. He's now at the University of Alabama, Birmingham. Um, but our group, we looked at our EEG source imaging results, compared it to our invasive EEG studies with all these patients. We had 87 patients. We had to throw a few out because of multifocal and non-localized seizure onset zones. Ours was a mix of low density and high density EEG cases. And in our practice, while we'd like to get high density EEG for everyone, um, a lot of times we think of this after the patient has left the unit, decide that maybe this would be helpful for the patient. So we're doing a lot of these post hoc and after the fact. So, patient's not there for us to add some additional electrodes and get a more um, dense sampling. So one thing that we did, I think that was different, and I think was an improvement over past literature, was we measured the localization we got with scalp EEG against the centroid of the invasive EEG seizure onset channels. Um, and other studies have used the resection margin, and that's difficult, but that's useful. But of course, the surgeon always takes a little bit of extra tissue. So you're measuring uh, you're measuring to an aggregate of pathological tissue and normal tissue, I think, when you do that. Our results were similar to the Broadbeck study, actually. Our concordance rates with interictal and ictal studies was very high, and we also found that ESI was significantly more concordant than expert reviews. We had some of our epileptologists review just the time series data and identify where they thought the seizures were coming from, and ESI did much better than our experts were able to do. So, we think this adds quite a bit of information to the system and a lot of value to pre-surgical localization. And then I've just any questions about that before I move on?
I do not currently see any posted at the moment.
Okay, excellent. Well, I'll take that to mean I've explained everything perfectly then. Um, I've got just some of the analyses that we typically do in our clinical practice, and just going to show you a few of the things that we do, some of the things we find helpful, some of the things we are a bit of a struggle, a bit of a challenge. This is, of course, the mainstay of EEG source localization. Your interictal spikes. We always start with a dipole cluster. This EEG is a little hairy. It's a little hard to see, I guess, but this midline, sort of oscillation that's going on. We map that. Here's an interictal polyspike burst. Uh, pretty clear on the left temporal lobe here. Uh, and again, just doing a dipole cluster is kind of helpful. One thing that we like to do is we look for outliers here. We plot all of these, and it's easy when you're marking to kind of disregard maybe an artifact or something like that in the data. We're used to looking past those things when we look at EEGs. So um, we'll often do these dipole clusters and find a couple that localize way away from the other dipoles, and we'll delete those spikes from our list. Um, and then, of course, I think where this really has a lot of value, really get a lot of use is when you start averaging your waveforms, because you're averaging out noise, improving your signal to noise ratio a great deal. Now, of course, the caveat is you have to make sure you're averaging or you're comparing apples to apples, and you're not averaging spikes with different localizations at the same time. But that's just something to be careful about. And to that point, here's a patient we had recently had multifocal spikes. A very interesting case. Um, the predominance, of course, of his spikes were sort of in this left posterior temporal quadrant here, but he had some that were they're fairly central, and then some that were actually right temporal, off the right temporal tip. And so, what do you do in that case? Well, this sort of shows you at least what I think the right answer is. You make a decision about which group each spike should go into, and then you just analyze them separately. And found a very nice localization here in the left posterior temporal region. This person actually went on to intracranial monitoring, and this was indeed where his seizures were coming from, and put electrodes in SEEG electrodes in there, and it was spiking away like crazy. And then, of course, the right anterior temporal spikes. Hard to know what was going on with that physiologically, but certainly those were a real thing that we recorded on the scalp EEG, and that you know that's not that uncommon, I think. Um, I mentioned earlier we like to do seizures when we can. A couple of caveats with that. Sometimes, of course, as you see here, seizure begins. You've got muscle artifact. You've got all kinds of stuff going on, and it can be very challenging to get a nice clean signal to analyze. Um, another thing that's a limitation about ESI with doing ictal analyses. I don't know of any good way to map electrodecrement where you see sort of the background fall out, and we can't really map the absence of signal, even though we know it may have localizing value. It certainly tells us that the seizure's starting, um, but it's just not something we can map. So one option in these sorts of situations is to map a sentinel sharp wave. That's what we've done here. Uh, you know, Came out right temporal, and of course, that makes sense with what we see here that starts up with the seizure after a bit. This was a case that Sam LaPalme-Remus in our group published a couple of years ago. This is a person who came in, had scalp EEG monitoring, had a very nice sentinel sharp wave, a little fast activity there too, riding on that sharp wave. Right temporal localization. Patient went on to have intracranial monitoring with a grid. Um, we found a very interesting pattern on her intracranial monitoring. So her sentinel sharp wave would would arise from these electrodes here over the temporal lobe, and then from there, the seizures would take two distinct propagation patterns. One was actually made a lot of sense in this red outline here. It was a temporal seizure onset, but she would also have an orbital frontal seizure onset with some of her seizures. So, um, that was a bit of a puzzle for us. But the sentinel sharp wave was identical every time. And this patient did well with, I believe she had a right temporal lobectomy and did very well. Neither seizure type came back. And I guess I didn't include her intracranial EEG to show you, but anyway, you can look up the paper, I guess, if that's of interest. Um, Another tool that Neuroscan Curie gives you that I think is really helpful is independent component analysis. This is an example. You can see here's an example of a seizure starting in the sort of left temporal area. Lots of muscle artifact in the recording, lots of other things going on. But if you identify an epoch and use ICA, it'll split the EEG into different components. Typically, you're able to remove some of the artifacts and leave the seizure discharge essentially unchanged. This works very well, by the way, for eye blinks. Those are very easy for the algorithm to pull out, and you can discard them, and the solutions are very good that way. It's not a magic bullet. Uh, sometimes you really can't get a nice clean seizure signature with this method, and you just have to do your best in those cases. Oh, and there, yeah. So I'm just showing that the muscle artifact was removed, and had a very nice solution out of it. This is one of our patients who had very frequent interictal spiking over the right convexity. This person had a prior grid implant and came back was still having seizures, came back for repeated monitoring. Actually, with the grid implant, they weren't able to do anything. They found that the seizures they thought were too diffuse, and of course, it's getting pretty close to some valuable real estate there. So we did EEG source localization on this. Here's our dipole cluster with the dipoles in green. And you can see we did an S. Loretta solution here, which identified this area, and this is our average waveform with the equivalent current dipole here in the operculum. These MRI images here are a little bit small, I suppose, to see, but really kind of completes the picture. This is a morphometric analysis that we've been running recently, and it identified this sort of opercular area as abnormal looking, both with the junction and, extension and junction maps. And so we evaluated this and thought it was a likely focal cortical dysplasia. Went on to intracranial monitoring. My image is not coming up for some reason, but these were actually the seizure onset zone electrodes here in red that we found. So it was concordant with the EEG source localization and the morphometric analysis of her structural MRI. Another case, this is a pediatric case, 15-year-old male with a history of hypermotor seizures. The scalp EEG was a little bit odd, a little bit hard to interpret, left temporal and frontal. And EEG source localization, of course, followed those localizations. This was an interictal polyspike burst that we mapped, and looked very temporal to us. So left mesial temporal. However, for the seizures, we actually had an ictal spiking pattern at onset, and we pulled out the individual spikes, averaged the waveforms, and did this analysis. And that mapped to the left frontal, superior frontal gyrus. That was actually in the general region of our ictal spect analysis. This person had an ictal spect while he was in the hospital. The PET was originally read as normal, but upon doing it through what we call the retrospectoscope, we did see this dropout of this hypometabolic area here, will drop out a signal. Again, superior frontal gyrus on the left side. Again, the morphometric analysis sort of picked some subtle indication up here. You can just kind of make it out here on the raw MRI, and of course the method, the morphometric analysis is a bit hypersensitive, so it's picking up lots of things, but this certainly stands out. And then we had this person underwent a 7 Tesla MRI, and that I think sealed the deal. We saw a nice little transmantle sign coming from the mesial part of the superior frontal gyrus. Stereo EEG monitoring identified that general area as seizure onset zone. Interestingly, I think his ESI result from the seizure was a little bit anterior to this, but certainly in the ballpark. And then just a couple caveats. I think we're almost we're coming to the end of our time here, but doing this in practice, um, just a couple of things to keep in mind. First of all, eye blinks, muscle artifact, any sort of artifact in your data, your source localization algorithm will very happily map that for you and give you something that doesn't make any sense. So, just have to be very careful about that. In terms of prior resections, we worry a lot in EEG about breach rhythms. Certainly, it does affect the voltage we measure. I'm not sure. I haven't seen a really good analysis of this in the literature, and that would be something that would be really helpful, I think, to have more data on how we should look at these situations, because a lot of our patients, they are coming back for they've had prior surgery and seizures have recurred. And of course, what you analyze matters. We always try to analyze the halfway point of the upswing of the interatrial spike. That's, I think, the conventional wisdom. You can sometimes get away, especially if it's a low amplitude spike. Sometimes we'll stay at the peak just to favor that signal to noise ratio over again propagation of the discharge. But that's something to kind of work out. And then you know be aware as well that the source localization algorithms always assume a focal source. So if you have something that's truly a generalized discharge, it's probably going to map to the thalamus, map to the center of the brain. Doesn't mean there's any reality to that. It just means your algorithm can't tell the difference between a focal source at the center of the brain and a distributed source discharging simultaneously. And I've just got a couple of examples of this here. These are eye blinks, and obviously it maps to the orbitofrontal area. And muscle artifact, temporalis muscle. It'll give you an answer. Obviously, this is not a right answer. You got to be a little careful too when you apply filtering. Don't map your filtered muscle thinking it's a seizure. And then a few references as well from the talk. So, any questions about anything in the time that we have remaining?
So we do have one question. It is, what do you think about the accuracy of ESI on deformed scalps or brain?
Deformed scalps or brain. I think it's fairly accurate as long as it's a contiguous surface. I worry a bit if there's a breach, but I think if it's megalencephaly or plagiocephaly, I don't really think there's any problem with doing those types of situations. I would use a patient-specific MRI if at all possible. Just you want to get the model really accurate. That's probably a situation where your atlas brain is still going to be a bit inaccurate for you, I would imagine.
Let's see, excuse me, we have another question. How long would you say it takes for this type of analysis, recording and/or analysis? Does recording high density take any longer than what is typically done?
Mm. The one thing about high density that takes a bit longer, and I'm talking about a prolonged study here, where you're using electrodes that are glued to the scalp. It does take a little bit more time for the techs. Actually, I think it often doubles the tech time for this. You have to glue on the electrodes, measure, make sure that everything's in the right place. So our techs understand that it helps, and they're willing to do it. I think if we said we're going to start doing this on every patient that comes to the door, we might have a mutiny on our hands, and understandably so. Um, in terms of the recording, though, once you have the electrodes on, everything goes pretty smoothly, and it's pretty much the same, uh, the same as a low density study. In terms of the analysis, generally the analysis takes, I don't know, a couple of hours. There's simple cases, and then there are some more complex cases that you can spend as much time on them as you're willing to spend, really. The simpler cases, though, probably a couple of hours is a good estimate. When you do a lot of them, you kind of you become pretty efficient at it. Um, and I really don't think there's a difference in terms of processing, in terms of how much time that you spend between low density and high density studies. It's really the steps are all the same, and it's just you've got more data to work with.
Got it. The multifocal results that you showed three different clusters there. Were those based on just that uh, topographic location, or did you separate those based on waveform?
Yeah, that's a good question. I can run that back real quick. I I think you can go either way on it. I like to look at personally. It feels more rigorous to me to look at the waveforms and decide, yeah, this is going to be, posterior temporal. This is somewhere in the middle. And I think one thing that is a good thing to do is look at these topographic maps when you're doing the analysis. And if they're all kind of in the same quadrant, you're probably okay combining them. In most cases, you know, I I probably look at the topographic maps first, um, along with the EEG, and then if things come out a little weird, like you can see here, there's a green one in the middle of this blue cluster. It's a little odd that it mapped there, but that didn't bother me that much. I think we just threw out the green ones because we figured it was probably an aggregation of left and right discharges happening, semi simultaneously. Um, there was a case I thought of just before the talk started that I was looking for and I couldn't find it, but we had one that was really interesting. Person had a perinatal stroke and a big encephalomalacia, lots of spiking just from this entire large rim of the remaining good tissue, and that one was really difficult because it was a continuous distribution. This was obviously a multifocal case. Um, because there was such a range of looking at the EEG and looking at the topographic maps, but it wasn't something that I was really able to divide into neat clusters um, in the way that I would have hoped or I might have liked to have. Um, so that's just something to keep in mind that those cases are out there too. Those sort of continuous, broad multifocal cases.
All right. I think we have another question here. Do you think in many multifocal spike cases, they are actually propagated from a single source? It is still from a single epileptogenic zone. Do you think in many multifocal spike cases, they are actually propagated from a single source if it is
Yeah,
still
that.
from a single epileptogenic zone? Excuse me.
Sorry. Yeah, that's a really good thought, and you may be right. I think especially where I would think kind of carefully about that is, um, if there's some evidence, for example, that it's insular, uh, the seizure onset might be insular. Um, you know, yeah, you might see very different propagation patterns for spikes, and um, it might look multifocal in interictals, and turn out to have a single focus. That's definitely possible. I've definitely seen some cases that kind of look that way. Um, I guess it's always hard to know until you put invasive electrodes in the brain and measure and look at what you find there.
I guess off the back of that, how much stock do you put into analyzing and looking at propagation across time in a spike?
Yeah, that's an interesting that would be something that'd be really useful, I think, to have more literature on, more data to kind of guide us. Because a lot of times, especially with a nice high amplitude spike, you do see this sort of propagation, a direction of propagation as you step through the upswing of the spike to the peak. And it's tempting to think, well, maybe if you take that cursor and step to the left, there comes a point where you run out of signal to noise ratio and the results aren't reliable. But is that directing us toward the source of where those spikes are coming from? I don't know the answer to that. I think that's a really good question, and I don't know, something I'd like to look at in our data, and I hope somebody else out there will look at too. I think that's an important question. It'd be tremendously helpful if that turned out to be something that we could use.
Let's see here. We have another. How many, what's the minimum number of electrodes that you consider as HD, high density EEG?
Yeah, typically we use 64 electrodes as sort of the cutoff point. Now, um, there's a big difference between, for example, having a 56 channel electrode array and a 21 or a 32 channel array. Um, I yeah, 64 is usually the cutoff point, but high density versus low density honestly is a little bit arbitrary where that point is. But yeah, we've been pretty happy with our 76 channel electrode arrays, and I think it's reasonable, and the techs, they're willing to put those on, and the patients tolerate it well enough. So that's I think it's a good compromise.
Okay, I'd like to give a last call for questions. Okay, well, turn on my camera here. There we go. I would like to, sorry, I'd like to thank our speaker, Dr. Brinkman, for the wonderful talk. Thanks everyone for attending this webinar. We'll see you in August for the next one. Please be sure to check your email or social media for the dates and speaker for our next event. And I hope everyone has a wonderful Memorial Day weekend. Not sure if you can see this, Ben. We're getting applause. You're getting applause.
Well, thank you for having me, William. Really enjoyed talking to everybody today. Yeah,
Oh, that
the,
that was incredible. I will probably be catching up with you about this. I'm curious to hear more about a few things, but I don't want to drag this on all Memorial Weekend. So
no
uh,
worries, no worries.
I think I'll be in touch.
Yeah, good. No, this is fun stuff, and it's been really helpful for us too. So really, that's a big part of the fun, I think, too. When you have a case that's hard, and people are able to
Yeah,
get
I'm
some value from
curious.
it.
I have a handful of methods I'm curious about,
Okay.
montage preference and yeah, and there's a lot of stuff that my own personal interest as I've learned about epilepsy myself. Again, it's fascinating. So like I said, I think I'll be in touch about some of
Excellent,
these things.
excellent. Well, sounds great, William. Sounds great.
Well, thank you very much, Ben. We don't want to keep you. I think we are wrapping up here.
Okay. Sounds good. I'm just curious, how many people did we have online?